So we can record this whole thing. And then I'm going to go back to this other view and see what I can do. All right.
Yeah, because we've got 34 yeses and only 13 have checked in. So
so when you're looking at this, do you see my control panel at all?
I see the panel to the right, so I can see who's talking and what the chat box is saying.
Okay.
Plus, then I have the actual PowerPoint slide.
No, Patty, we don't see your control panel now.
Thank you. That's what I wanted to know.
Yeah, I just see mine. Okay. Okay, so being we only have 14 of the 34, suggestions, shall we get started?
Yes, please.
Let's go.
Okay.
Let's get started.
Okay,
yes,
get this
please.
ball
I'm
rolling.
sleepy.
Well, this is Kathy Forbes, and Patty D is in the middle of moving boxes and whatnot, and she may or may not be able to jump in here, but our advisory board has kind of decided on how we're going to make this meeting move to get the most out of it. So we will do our best, and we're on record right now. Today, go ahead and move ahead, Patty. Patty B is going to be my advancer of the slides. Hello.
I'm trying.
Patty?
There we go.
Oh, okay, there we go. We'll try and keep it at 60 minutes. That's my goal. But at the same time, we're going to be talking about code submissions and what the different groups have been doing. So it might extend. So planning on 75 minutes, hour and 15 would be, we will cut it off at that point in time. So again, thank you all for participating on this last Sunday in August, for crying out loud. Okay, moving ahead, we have an agenda here, and one of the things that we talked about at our last meeting was that we wanted all members of the DCC to have purchased the CDT 2018 books and the CDT 2018 shifts. So just a reminder, if you haven't done that yet, please do so. So that when we start talking about these codes and whatnot and referring to them, you can have your manuals handy at either these meetings, or even if you're in a work group, at those work group meetings. Give you the background and all the stuff you need for as we talk through some of these codes. So just next slide, the quick review, the DCC's mission. First of all, we have our advisory team, and you've seen us all, and we're still working in the background trying to help all our work groups to be productive. And Patty and all of us are so thankful that we can be a part of this organization. So moving ahead, a quick review of the DCC's mission. And by the way, we are not going to do a roll call tonight just because of time and what we need to cover. And I believe everybody has been on at least one of these meetings before. Is there anyone who has not, this is their first time? Is there anyone out there?
Kathy, this is Becky Comstead. I have not been on one yet.
Oh, Becky, hello there, another Coloradan. Welcome.
Yeah.
Welcome. Becky is our Boulder, Colorado component trustee and the person behind the influence of the RDH companion website. So thank you, Becky, for being a part of this.
Yeah, thanks for having me.
So the consortium's mission is to influence the creation, definition, and maintenance of dental diagnostic and procedure codes, and that's what this meeting time is going to be focusing on. So moving ahead, one of our goals is that we will represent other professions. And after we had created this a couple meetings ago, our advisory committee was talking about, are there any other groups that those of you out there have maybe thought about that you think might want to be included that are not in this current list?
Kathy, what about educators?
You mean dental hygiene educators?
Yeah, well, not just not teaching dental hygiene in a dental hygiene school, but people who are working, say, in public health, or for that matter, just working in any aspect of health, that their primary work is educating their patients.
Okay. Any other further thoughts on that? Part of me was thinking in terms of nursing. My goodness, we've got certified nurses working in facilities that, you know, where they're doing a lot of the hands-on dental, oral health. So that was only my thought. Okay. All right.
What was the thinking on, Kathy, what
Yep.
was the thinking on, this is Jill, what was the thinking on dental therapy? What was the thinking on that? An example.
Well, the dental therapist group that are starting to organize, you know, there's how many states that have some form of regulation for dental therapists. So it's my understanding they're starting to organize to a certain extent. So we would involve them. And maybe that should say dental therapists rather than dental therapy. Maybe that would be clearer.
I think that would be good.
Okay. Okay.
And also, what about specialty groups like academies of different associations, like the Academy of Periodontology or the Academy of Pediatrics or something like that?
I agree, but they're already on the CMC, so
Oh.
that would
Okay,
be
well, I
one
was just,
thought. Yeah, no, I hear
I
what
was
you're
just trying to think of those.
Well, the Academy of Dental Hygiene. What is that?
Right.
American Academy of Dental Hygiene, but that's already in the representation for 1A, dental hygiene.
Yeah.
Yeah.
Okay. Well, if I encourage the rest of you, if you over the next, you know, before the next meeting, if you think of other organizations, let us know, because we're fine tuning this infographic that we're creating, and don't want to leave someone out that probably should be there. So, okay.
Great.
All right. Moving along to the DCC's number 2 goal, which was to foster CDT manual consistency in nomenclature and descriptors. And with one of our primary goals of being no procedure or diagnostic code should be limited to any provider type. And we'll be talking a little bit more about that in each of the section groups that we'll be heading into here. And then goal number 3 is to write and submit proposals. And we'll talk about that as we get to the end, where we're at, what our timeline is for this current Code Maintenance Committee meeting, which is in March 14th and 15th in Chicago. So how we can do that and with all the section groups. So I'm excited personally to hear about the section groups because I'm involved with one, but I know the others have been meeting, and we'll see where we go from there. So just a quick refresher on the categories of service that the ADA has defined. And we have been focusing on diagnostic, preventive, periodontics, implant, and adjunctive general services are the 5 work groups we've created because we've identified potential submissions that we might want to do in each of those. So what makes a successful work group? This is just from last time's meeting. Next slide.
Sorry.
That's okay. Appoint strong team leaders, which we have with the assistance of the DCC advisors. We certainly, this is a learning process for many of you in terms of how this whole talk about a code, how to develop it, what we need to be able to support it. And the advisors worked diligently last year for the 6 codes we submitted. So we would never appoint a team that didn't have an advisor close at hand. Knowledgeable in subject matter in Zoom or GoToMeeting formats, and we're all getting a little better at doing that. We want to have a designated consistent schedule and meeting time that's determined by the majority of the group, and we're going to be we've got November 1st looming over our heads, so having that kind of schedule is important. Input from every member. Those of us on the advisory committee cannot overemphasize the fact that you are the people that make this happen, that your input and your ideas and your opinions are so important for these tasks and how things can be written. So we want to be very transparent and very open to, there's no bad question, there's no bad comment. We value all the knowledge that are sitting in, and I'd hate to add up all the number of years of hygienist practicing we have just on this phone call with 23 people. So we need everybody's input on it. Suggestions from other organizations or people, you know, we need to reach out, and we'll talk a little bit about that later on this evening. So what I want to do is start with Natalie and talk about she is the team leader for the diagnostics section. And the diagnostics section includes all the diagnostic and clinical oral evaluation procedure codes. And one of the things that all the work groups will be doing is looking at the terminology in terms of making the suggestions to amend to take out any reference to a specific provider. We tried to do that with the clinical evaluations last year, and I think they got the message, but each of these 5 sections, we need to take a look and see if any specific provider is mentioned, and we'll write an amendment or an edit, whatever, to ask that they take those out. So Natalie, I'm going to turn everything over to you and let us know what has been going on with your group.
All right, thank you, everyone. This is actually my first meeting, and since I volunteered about 3 weeks ago to chair this position, unfortunately, I haven't been able to do anything with this group. However, I don't think that means that none of the committee members haven't done anything. So, sorry.
Okay, that's okay. Hey, thank you for taking it on just 3 weeks ago.
Oh, and I'm also representing the dental assistants.
Oh, good. We need their input, believe me. Are Lucy, Sandra, Deborah, or Linda Jorgensen on this in this meeting right now?
I'm here, Lucy Connard.
Okay. Has there been any meeting with you folks yet?
I haven't been contacted by
Okay.
anyone, so I'm not sure what's happening.
Okay. Okay. Well, I might encourage, well, I'm not sure what, I thought Linda was going to be on this phone call, but reaching out, she was a big part of writing those initial codes for last year. So Natalie, I might suggest that you just kind of reach out to Linda and say, okay, let's get going and see what she has, you know, cooking in the pot for this kind of thing.
Sounds fabulous.
Okay. And in the meantime, your group can definitely be looking through that whole section in terms of determining if a specific provider is mentioned. I mean, we know it is in the oral evaluation section, but take a look at, you know, where those are, and we can help write, you know, the change request to be able to pull those out. Okay.
All right. Thank you for your helpful hints.
Sure. Thanks, Natalie.
Mm-hmm.
Okay, Howard.
That Linda Jorgensen just joined us.
She did,
Yeah,
Linda.
I was going to say Linda's on now.
Hello, Linda.
Hi, sorry, I've been kind of AWOL for a while. I apologize to everybody. I made it to this meeting.
Yay.
Thank you. Yeah, it's a long story, but yeah, I'm here.
Hey, life happens and you're here. That's all we care about.
You
So
know.
I just was telling Natalie to go ahead and hook up with you, you know, and start kind of the ball rolling, looking at those references that we talked about, practitioners, and that we went over last year, so that you can take a look at those. So, okay.
Yes, good.
Okay.
Thank you.
Okay. Okay. All right, Howard, preventive section.
Yes, thank you. So we're working on preventive codes on 2 fronts. We're conducting a Delphi type discussion to develop a conceptual framework. The way Delphi type discussions work is everybody puts in input multiple times, so that we kind of eventually triangulate on certain concepts, developing a theme and identifying the specific variables that in the future could be studied. That seems to have stalled over the past few days.
Yeah.
And we're also conducting a literature review to find the scientific evidence behind whatever procedure codes we may recommend to the Code Maintenance Committee. The literature review process is early, but from what I'm seeing so far, there seems to be a strong disconnect between the literal meaning of prophylaxis, prevention, and the operational definition used by researchers, which is polishing with a rubber cup and abrasive paste. And I think it's no wonder they don't see any health benefit beyond what somebody could do at home with a toothbrush and toothpaste. We haven't triangulated on any specific themes in the conceptual framework, but I have noticed a significant difference in opinion among the group regarding a child versus adult prophylaxis. One opinion is that there's a distinct difference between providing a prophylaxis to adults and children because of the relative amounts of deposits on each group. And the other opinion is that each patient's treatment should be based on the findings on that patient rather than on the group to which that patient belongs. Likewise, with the decision to offer fluoride treatment. We have also been discussing if or how we should be expanding codes for diagnostics, and that information I'll refer to the subcommittee on that section on diagnostics. Yeah. And we're also discussing expanding codes for consultation with other health professionals, treatment of patients with systemic illnesses, and oral hygiene instruction. Instead of just OHI 1330, we should have a whole bunch of codes, perhaps, with the various things we might do as far as instruction is concerned. Overall, we see at this point we should have 3 prophylaxis codes, adult, transitional, and deciduous dentition, that are truly in the presence of healthy teeth and gingiva, and a code for scaling in the presence of gingivitis less severe than generalized moderate to chronic gingivitis. Okay?
Okay. Patty, you want to go to the next slide?
Sure.
Kathy?
Yes?
Hi, Kathy. Tammy Flipiak, immediate past president of ADHA. I've been on here for a while, but didn't want to interrupt. I just want to make a note here in listening to Howard talk about the prophylaxis piece. We just came off of our executive committee meeting today, and while I can't discuss the topic related to that, I will ask Michelle Brehrman to follow up or provide me something on that for you all in the timeline of when that comes to our board as well.
Okay. Thanks, Tammy. Okay, so this is Kathy, and one of the things that our group was made aware of I might be repeating myself, when the American Academy of Pediatric Dentistry offered a change to the prophylaxis definition at the CMC last March. Our group offered amendment, and it was all turned down. And one of the biggest things is AAPD wanted just one term prophylaxis. And the insurance carriers, NADP, National Association of Dental Plans, was adamant that if it came down to only one prophylaxis code, they were going to reduce the benefits. In other words, kind of average what child and adult were. It was pretty strongly put, and of course the CMC voted that down, so that didn't happen. But in talking with a rep from the AAPD, they had gone to the Association of Dental Plans just a few months ago, and were told they want to make it age dependent. And they were going to be coming back at this next term to talk about that. And our group has been totally against having it age dependent because that doesn't work. And so our group decided that we would suggest and to have 3 different codes. If you go back a slide, Patty.
Okay.
That we'd have the 1110 permanent, 1120 transitional, whoops, and 1130 primary, because a prophy is a prophy is a prophy. And as Howard had mentioned, from the research we're finding, doesn't matter the age, you still set up the same, time's still the same, it's still the same thing no matter what the age. You can have adults that have a transitional dentition because they have retained primary teeth. You can have 10-year-olds with permanent dentition because they lost their teeth prematurely. So in terms of metrics and keeping track, we are going to suggest presenting 3 different codes. Now, we wanted to expand the descriptor to make it more, oops, someone needs to mute, okay. The descriptor would be mostly for healthy. So if you go to the next slide, when you consider what the AAP has done with the new disease classifications, we took from that and wrote a new descriptor, and it kind of took, and this is all open for discussion, but took that, what has just come out of AAP for the descriptor, and then I went back to CDT1 in terms of, I kind of like their definition, which will be the next slide, but let's stay on this a minute. And we thought this might, from everything that's been talked about over the last 2 years, performed on patients in normal or good periodontal gingival health on an intact periodontium to remove coronal plaque, coronal calculus, and coronal stains. Since there is no clinical attachment loss, scaling and polishing are performed into very healthy, shallow, healthy sulci. Removal and disruption of biofilm, plaque, calculus, and stain can usually be completed in 1 appointment. Before we do anything, we want to at least be able to, and that's why our group is delving into the research to see whether prophy is even a viable kind of procedure. But if we go to the next slide, just for your information, and by the way, this PowerPoint is in Dropbox already, so you can get, this is what we kind of modeled after the original description from CDT1, which was from 1990 to 95. And it really was for good periodontal health, normal health, coronal plaque calculus and stains, pockets absent, etc. So we thought if we back up to the previous slide, Patty, and kind of incorporate some of the new classification systems into prophy descriptor, it might make it a little better. But then that left us, what do we do about the gingivitis patients? So if you bump ahead to, we're suggesting a new code. If anything, a D4344, but it'd be in that category, and it's the bridge between prophy and the 4346. And we'd put scaling in the presence of localized to generalized slight gingival inflammation, full mouth after oral evaluation. And we modeled this title after what has already been passed, the 4346. Scaling in the presence of generalized moderate or severe gingival inflammation, full mouth after oral evaluation, so that we could touch on the gingival inflammation that many of you had recommended. We needed that kind of bridge between prophy and the 4346. So when we got to go to the next slide, talk about the descriptor for it, we really delved into what the new AAP categories were, and started it out like the 4346. So removal and disruption of biofilm, plaque, calculus, and stains from super and subgingival tooth surfaces, indicated for patients whose oral condition may range from clinical gingival health on an intact periodontium, clinical gingival health on a reduced periodontium, dental biofilm-induced gingivitis, and or non-dental biofilm-induced gingival diseases, which are all brand new in the new system. This may include slight to moderate bleeding on probing. So what we've tried to do is go from prophy on dentition-based to this localized gingival inflammation, and then we've got the 4346 moderate to severe. So that's just our first ideas of our group, and we certainly could, we tried to look at all the comments made over the last 2 years by all of you, but so anything else that you might suggest that we do to tweak it, or we just need your input now.
Kathy, this is Noelle Paschke. I have a question for you. So on this descriptor, you're actually saying clinical gingival health, and then it's going on to refer to gingivitis. And so wouldn't the prophylaxis codes by the dentition, the 3 groups of dentition, wouldn't that then be for your healthy? I mean, so why are we saying not, we're saying gingival health in this one, when in fact I thought this one would be for the slight or mild gingivitis?
Good question. These descriptors are straight out of the AAP. So in terms of how it's worded, that's out of their, lingo. I hear what you're saying. I think our original intent was meant that a prophy would have no clinical attachment loss. So that we wanted something, and maybe we need 2 4000 codes, one with healthy clinical attachment loss is its own code, and then biofilm-induced gingivitis. We could split those into 2 more. Is that what you're saying?
Possibly. I think we need to just be very, as we segment and slice it and dice it. Certainly we want to keep it within the AAP's classifications, because this is not the time for us to argue with them about the classifications. It is what it is, and we need to work within those parameters. At the same time, I think our goal overall is to eliminate the super duper prophy and a subsequent dental hygiene burnout from us working way too hard on a particular, or too long, and then we run behind schedule. So it's like, as we slice and dice, I just think we need to have some segmentation of the healthy patient versus the sick patient.
Yep.
Right, so maybe the clinical gingival health should be taken out of there, because then
and put in the prophy,
that part should be prophy by definition.
Right.
Yep.
Howard, I agree with you. And as long as it's still within the spirit of the AAP classification, then I think we would stand on good ground.
Right.
So this is Connie. So basically, this is where they're going to take those 4910 patients that aren't technically periodontal maintenance, but have gingival health just on a reduced periodontium. Is that correct?
Yes, that was the idea.
Okay.
That would be me.
Yes, Patty, and we love you for that.
Yep.
And it's so much fun.
Yep. Okay, well, I like that idea, moving that gingival health into the prophy.
Well, maybe a reduced periodontium. There should be people who have never been diagnosed with periodontitis being one code, and people who have been diagnosed with periodontitis but are now healthy with another code. Just a thought. I'm not sure if that should be, but it's worth considering.
Any other thoughts?
This is Kathy Stewart. I think what gets confusing is the new AAP language is more classification or diagnosis versus treatment. So when we try to move that classification into a treatment code, it gets a little fuzzy. So I think I think that's the issue, is you have to reword it so that it's actually treatment versus classification.
And I agree with you, Kathy, that it should be just on the actual procedure. Absolutely. The thing is, what we have found, and I found, and those who have submitted codes, you kind of got to step back to help these folks understand. And so,
I get that.
It's like, I really don't want to put it in there, but if they're going to understand it, we got to kind of, I don't want to say muddy the descriptor, but we got to spoon feed them.
Okay.
At this point in time is where we came from. I agree with you totally. I wish it could just be a procedure without the diagnosis in it, but it'll be tough to fly. Okay.
Sure, I understand.
I want to hear more from Janet. Jordan, that just put the comment about the super gingival only.
Yeah, there's always, I work for a large corporate, so they have like these territory hygiene managers. And when we have our like territory meetings, they're like, Remember, a prophy's only above the gum line. If you go below the gum line, then you're scaling. And I get on my soapbox all the time about if there's no clinical attachment, but you're reading a 3 millimeter probe depth, well, there's 3 millimeters of coronal portion of the tooth. So they're interpreting coronal as only what you just get what they can see. That's what bothers me.
There's clinical crown. There's clinical crown. And then what's the other?
Excuse me, I've got a phone caller.
I would say something like maybe all accessible tooth structures or tooth surfaces.
If you read the description that they have now, it says from the tooth structure. It doesn't say, I mean, the prophy. It doesn't say only the clinical crown or the visible clinical crown.
Yeah.
I know, but that's what they're interpreting.
Well,
I've been told so many times, and I hear people, and I see on some of the Facebook groups too. It's no, oh no, it's only supragingival.
Who is
people really think that a prophy is only?
Who is
In my particular office, it's our territory manager, which is the PA Ohio area. Basically, the Aspen Dental.
So you do not like the word coronal, which just means above the gum line. What do you have a suggestion for a different wording that would talk about?
I was thinking more like all accessible tooth structures. So if you're able to access it with a probe, you should access it with an instrument or something along those lines. I mean, a lot of it I think is just lack of education on their part. But
yeah, because the point, since there's no clinical attachment loss, was supposed to kind of cover that.
Right, because if there's no loss, you've got the clinical attachments at the CEJ, but if you're getting 2 and 3 millimeter readings with your probe, then there's 2 or 3 millimeters of enamel surface or coronal surface that is subgingival that you should still be cleaning, but they think it's only above the gum line. And it's not just at my office. I've read some different debates on some of the Facebook groups as well. And they really think that a prophy is only above the gum line.
Yeah.
I just had a cleaning by myself at the office.
Hang on a minute. Someone's trying to, was that Tammy?
Yeah, Kathy, it's Tammy. And I think that the point that's being made about the confusion is because I believe there was a time when the prophylaxis language did say something like that, supragingival. And I'm driving, and so I think I heard that Pat's on here. But I think that tells us a bit about our community in their understanding of, you know, that language can change, and then what does it mean for what we do. So I think it's because of something that used to be and is no longer.
Okay.
Yeah, about 6 years ago, it said coronal structures.
Right.
Kathy?
Yes.
I just coming as this is Linda, as a former dental anatomy instructor, we made a big deal about defining what we mean when we're talking about the crown of the tooth. There's the anatomical crown, which is everything that's enamel and does not include cementum. So CEJ ends the anatomical crown. Then you have the clinical crown, which is everything from the gingival margin up or towards the occlusal direction. So if you have recession, exposed root surfaces, all of that area of exposed root surface is included in the clinical crown. So when you're polishing supragingivally, you might be getting some root surface. You might be even getting into furcation.
I keep getting dropped. Thank you.
And then there's a third definition of the crown. Well, I don't know, maybe it can't be considered the crown if you're going beneath the gingival tissue into the sulcus. Sometimes the sulcus is 1 millimeter, and then other times, as we know, it's very deep. That can't be considered the crown in, under any circumstances.
Right.
So And everything gets more complicated the farther apically you get away from the CEJ.
Right, and I get it. And that's why this preventive prophy code has no clinical attachment loss.
Right.
So in other words, if you can probe down anything below that CEJ, it bumps into the 4,000 codes.
Right.
Was the intent. But maybe, you know, we need to take a look. The last time the word coronal appeared in the adult prophy code was in 2005. They took it out in 2006.
Yeah.
So they just made it 2 structures. So if we, you know, I hate to say to remove deposits on the enamel. I mean, we could, you know, if we wanted to truly, you know, stick with, everybody knows where the enamel ends.
Well, no, even that, if somebody has toothbrush abrasion or abfractions, the anatomical crown may have some dentin exposure.
That's true.
Hey guys, this is Denise Narski. Hello. Hi.
Hello,
Can everyone hear me? This
Denise.
is Denise. Hi. Usually I'm pretty quiet on this, but because I coach dental practices, the big thing that I'm hearing right now is we're all anticipating that hygienists are actually picking up a probe and perio-charting the patients. Every practice that I go into, the first question I ask them is, so how often are you perio-charting your patients? Once a year. We do it alternating when we do our bite wing x-rays. Now my blood boils as soon as I hear that, because how can you physically assess what you need to do? Instead, you're driving blindfolded into someone else's infection without even knowing what you're up against. So we're talking about all of these different things, and we're going to be confusing the hygienists who automatically right now are thinking, I'm not probing. I hate the word probing, but because none of us want to be probed in anything in life. But if we're not probing and we're not assessing our patients, then we don't even know if we're doing a prophylaxis or not a prophylaxis.
Exactly.
So that's what gets me all crazy is these offices. How can we instill in the doctors, in the hygienist, that, hey, guys, before you touch this patient, I don't care what it takes, you assess them, no matter what you do. That will determine what you need to do from that point on. So hearing about, you know, are they going to scale above the gum line, below the gum line? Are they going to scale in the fractions and recession? Great, we can all say that, but we have to train the hygienists that are out there. Hey guys, pick it up, measure, assess for inflammation, infection, biofilm, bleeding, look, because even when they perio chart, they do not look at anything but those numbers.
Right.
They're not even looking at how many bleeding points do they have. Is it a 30% or more of bleeding to go to a different category? They're not looking because they're not doing. So that's what I just wanted to bring up. And that's where we're going to have some difficulties. If we're going to start confusing the whole language, who's going to teach them besides us coaches who are going to walk in the door and start demanding, hey, this is the new standard, it must be done. Otherwise, how is it going to get across?
Yeah, well, we're going to have to rely on our educators too to pick this up. Okay, great comments. Thank you, Denise. I appreciate that. So in terms of these particular codes, the descriptor, what I'm hearing is we've got to somehow define what part of the tooth or how much of the tooth or where the tooth above the CEJ we are going to be doing a prophy on. Is that what I'm hearing? So it's coming up with the definition of what we're talking about. And I've got all sorts of little notes here on this thing, but anyone have, I mean, Janet talked about all accessible to structure, but we want to make sure we're not on dentin. We want to make sure we're not on cementum. We want to make sure there's no, maybe the no clinical attachment loss needs to be at the beginning of the descriptor. But we wanted a descriptor that would fit all ages. Is that correct? So if you have any other suggestions, I want to make sure we don't run out of time. You know, the thing is, I so appreciate Denise, because I've worked with offices and coaching them and getting them to be consistent with their assessment. It's like the biggest thing. I get questions on what procedure should I do? I said, what's the diagnosis? Well, I don't know. You know, it's like going back to, you can't make a determination of a procedure without having a diagnosis first. And that's, you know.
Hey, Kathy.
Yes,
it's
Tammy.
Tammy again. I just want to chime in here too, because I would question whether it's knowledge or desire. Because I believe there's a knowledge of what should be done. It's the desire to do it or not. So I can appreciate what Denise is saying, and we've certainly all worked with colleagues where we've maybe encountered that. I also like to always highlight, you know, some of the resources as we go through this work, but particularly as it relates to assessment. It's a piece of the standards for clinical dental hygiene practice, which are available on the ADHA website. So to the extent that that can help anyone on this call in those conversations, I think it's a wonderful document.
Okay. Okay. I want to make sure we get to everybody. Any comments? I got Noelle's comments about the new code, the scaling and localized to generalized. Any other comments on that particular descriptor? As we, you know, this was our first draft, so we'll take any kind of comments, and certainly you can send them on to Howard. Look on the list and send them on to him, and we'll keep working on this. But thank you so much for all the comments. We on that group really appreciate it. What's been interesting, and Howard can share a little bit more, is the research is showing that prophies aren't even really necessary according to some of the initial research we've pulled. So that's a whole nother thing.
They're having a bad definition of what prophylaxis means.
Uh-huh.
The researcher's definition of prophylaxis is polishing.
Yep. Yep.
Yep. You know, it's poor validity of the research.
So by next meeting, we'll have more of that research to help talk about, but I've got scribbles all over my PowerPoint, so thank you all. So I'm going to turn it over.
Just one more quick, I hope it's a quick question. We discussed at one time calling some of these codes, instead of a prophylaxis, prophylactic debridement, because what we understand about what we're doing or should be doing with a prophylaxis now is removing all of the stuff, the plaque calculus and food debris, other debris, the stains from a tooth surface, as long as it doesn't, we're not treating periodontal disease. That's a different thing. But a prophylactic debridement, could that be used? Have we talked about using that as the descriptor for these codes? Instead of prophylaxis?
I think really like that, because one of the things that we need to always be mindful of, so we're dealing with politics also, okay? And so we want to make sure that we come in, I mean, with something that the other organs, because AAPD is going to be submitting this, you know, that we can all live with. And I love this idea of a prophylactic debridement myself, and I could weave that into the descriptor, absolutely.
I think we need to reject the idea, I think it's erroneous from start to finish, that a prophy is just polishing. It's not, we know that it's not, but I agree that it is perceived to be that way by many. So we don't need to talk anymore about that, but thank you for agreeing with me, because I was like, okay, can we please make this prophy equals polishing thing stop? I don't need to do that.
Yes.
Howard, you had one more thing, I think?
No.
Okay. All right. Okay, we're going to move on to Val, who's the team leader for the periodontic section. Hello, Val.
Is Val on the call?
Oh, I thought.
let me just check the
list?
roster here. I don't think she's on the call. It's Noelle Paschke. So I was sort of the advisor for that committee. And so Val's had to take a temporary leave of working on the committee. And so where things stand right now, some of the things that fell under this section had to do with lasers and potentially subgingival air polishing. So there was testimony given last year related to those two topics. And I think that, based on what Howard's reported and some of the vigorous discussion that we've just had, that really the essence of what, as we move forward, is that we absolutely must nail this idea of prophylaxis. And because I think it's at the heart and essence of what dental hygienists are faced with from an ethical dilemma every single day. And so as far as this particular committee, one of the things that, and Barbie Lynch and I just had a conversation earlier today about this. And so when we take a look at laser, and that while there's certainly a lot of information on diode lasers and what it can be done, the way that most of the research has been structured has not been in such a way that allows a meta-analysis to be done, and so being the highest level of evidence that you have to base your decisions. We also know that the AAP has perhaps would not be totally supportive of some of the research that is out there. Not that would make us shy away from proceeding with that, but I think that as we're doing this, that we've got to build coalitions. And one of our original goals when we first started was not only to produce testimony for various changes to codes, as well as providing new codes, but really the ultimate goal is for us to have a seat at the table, a voting seat at the table. And so part of that coalition building, I think we just need to be very mindful of what codes we're and what areas we are presenting for change or additions. So I really think that for us to try to proceed with laser codes at this time, I think the timing is off.
Okay.
And I don't, I'm certainly, I want to hear people's opinions that they might think that that's totally just, makes no sense at all. And then with the air polishing, we know that the subgingival air polishing research is in fact very strong. And perhaps that should be more under things related to the cleaning up the implant maintenance codes. And so the perio section does not have anything specific to report this evening, but, that's where things stand right now.
Okay. Great. I totally agree with you that I think that our focus should be within that preventive prophylaxis section, and we'll come up with a stronger plan for the next CMC this next year. So any other thoughts on that from anybody?
I have a question. This is Connie. So as I told Noelle, there was some confusion early on about who was in what group, and we accidentally got put into Howard's group, and we were actually supposed to be in the perio group. But anyway, as a group, are we ever going to, I know the gingivitis code is brand new, and we're still dealing with all of the settling from that. I would like to see that by evaluation first taken off of that code eventually, because for me, it just muddies the whole thing and why people aren't using it. That's what I'm hearing from. So that's just my take. I know we're not dealing with it right now, but for future, I think if we can come back and address that, that would be awesome. Goodbye. That's all I wanted to say.
Okay, Connie, just for clarification, you mean in the nomenclature you want to take after oral evaluation off?
Yes. More people are telling me that that's why they're not using it, because it screws up their whole day with having to have the doctor come in first.
And historically, I think that language, Connie, I totally agree with you. It's Noelle again. I totally agree with you. My understanding, though, and Kathy, I know that you're really the historian on most of this, is that the reason that it was by oral evaluation, that was more of a political situation.
Right, we
from
compromised.
From the dental community, that way a doctor would still be involved, not a doctor, would be specifically a dentist, would be involved in the procedure and authorizing it first. But it's a schedule wrecker. It doesn't help the patient. It's like I always keep going back to two things. Does it help the patient, and does it improve clinical outcomes?
Well,
and
Noelle, what we could do is we could submit a submission to take that off. All they can do is say no.
Yeah, but I think I think we should certainly involve ADHA in that
Oh,
process.
absolutely.
Because
Absolutely.
that is and gain support right there from our own constituents, because that potentially taking that out would be like shaking up the wasp nest.
Yeah.
I agree with Connie. It needs to go, but how we make that happen is going to be critical.
Yep.
Well, yeah, I think it's a little too early.
Okay.
Yeah,
Okay.
This is Kathy Stewart. I don't think we should take it off. And it doesn't say who does the oral evaluation in that verbiage. So technically it's still a procedure code, it's written as a procedure code, not a provider code, because it doesn't say who has to do the oral evaluation in the descriptor.
And there are states which already say who can do oral evaluations.
Right. So it would go back to the state board. So really I don't have a problem with it being in the descriptor, since it doesn't indicate who has to do the oral evaluation. That goes to the state level.
Yeah.
Well, as Linda was pointing out, every procedure should start with an oral evaluation.
Right.
Exactly. That's what I was gonna say.
Exactly.
Yeah.
Yeah, I mean, that's why it doesn't bother me. And then only one other thing I wanted to say too, I'm going to go back to what Tammy and Denise were saying about knowledge and desire being part of it. The other big piece of it is awareness of the codes by clinicians, both dentists and hygienists. I think there's still grassroots providers think of it as a payment method versus a clinical description. Yep. So, anybody that's done any coaching or consulting, that many providers, both dentists and hygienists, have no idea what the codes are.
No.
Or what they just use that standard code set that they've been using forever until someone tells them it's been, changed or modified or deleted. So I think that goes back, and I'll defer to the educators on the call. Do you teach anything to the hygiene students or the dental students about coding? My experience being in the classrooms, when I ask that question, they know very little about it or have not been exposed to it, other than here's what we allow.
Kathy, I think
yes.
To answer that, in addition, a lot of the computer programs that they have, their software only gives a few words about what the code is. It doesn't give the whole description, so no one ever sees the whole description.
That's true.
Yep. Well, teaching in an education, I teach in an educational program, and I've only been there a year, but they just taught the nomenclature. They did not teach the descriptor, and it's driving me crazy. But yeah, it's just like, I don't know. That's right. I forgot this is being recorded. But, it's like, they've got to understand the descriptor. And I think all educational programs need to really push that. Anyway, great comments, Kathy. Thank you so much. We'll see where we go from there. Noelle, do you know is Val going to be able to do anything, or are we just kind of putting your group on kind of hold for right now?
Well, putting our group on hold, and that's my understanding at this point.
Okay. Okay.
And or shifting it to other areas.
Okay. All right. We can do that. Okay. Let's move on to the implant section. Melissa, I think I saw you are here.
No, Kathy, this is Jill, and Melissa is not here. She called in. She could not be here. So I'll fill in for her and what we do. Okay. I'm the advisor of the group. Okay. So the group met August the 22nd. We went over the submission form, and as far as the nomenclature and the descriptor, what it means. We reviewed other implant codes. We discussed implant code D608 and D6081. We reviewed that. And what we did is the group came up with 3 different codes that they'd like to see submitted. And the first one is the evaluation and or therapeutic decontamination of dental implant superstructures. The second one is subgingival treatment of perimucositis and periimplantitis surrounding 1 to 3 implant bodies. The third one is subgingival treatment of perimucositis and or periimplantitis surrounding 3 or more implant bodies. and we have another one that we haven't quite defined yet. But we also we also went over to the political part of it and looked at the descriptor and so on and so forth. We have another meeting coming up on the I think it's the 17th. We're scheduled every Monday night for our impact group. We can have them submitted and what we've come up with so far. But that's what they've done. They worked really hard to come up with what they would like to see.
Awesome. Awesome. Do you have the do you have the code
I'm sorry.
Do you have the code change forms to fill in?
I would like one sent to us so we could have that done. No, I do not.
I just put one in the Dropbox under this meeting. It's 3 pages. Yeah, I just put a blank one in there, so you should be able to start filling that in.
So
we'll
Jill,
fill that in.
I'm sorry.
I'm sorry.
Yeah, Jill, it's Noelle Paschke again. So I have a question for you that within, I think it sounds like you guys have done an awesome job. Where does the cleanup on D6081 fit into what you just described?
Well, that's just it. I asked about that, and I asked Patty about that because I think that's the one with the single implant. And she kind of advised us to kind of stay away from that right now, to go with our own. That's why we went with the 1 to 3 and 1 to and 3 or more. So we did not do any revision on that one. We looked at it, but we didn't do any revision on that, and that's subject to what we're going to be pursuing. So does that answer your question?
Yes, in part it does. And then, so I know that there was a section of that code that also had a prohibition of doing that on the same day as other codes, which seemed rather from a workflow standpoint, it just seemed like it really provided a hindrance.
Right.
So
and our other ones.
If the patient had, so for example, if a patient had like a single implant and you wanted to do the 6081, but they also had moderate to severe gingivitis, the way it's currently written, it does not appear that you'd be able to provide both of those codes on the same day.
Right. And I think it states that you can't do both of them on the same day. So, but we did not touch that. We did not revise that at this time. But we have things included in our other codes that we will be doing on our other codes from 1 to 3 and so on and so forth that you can in conjunction with. So we'll have a full description for you. We'll work on that description for you and get into scientific evaluations and so on and so forth. Everything that needs to be put into those things that we can review.
Awesome.
And any other questions? They worked really hard coming up with just.
Sorry, Jill, this is Connie. Connie, one thing that I heard as you were reading the descriptors, so in the first one that you said 1 to 3, and then in the second one you said 3 to more. So it's going to either have to be 1 to 3 and then more than 3. Is that really what you meant? Because it can't be 1 to 3.
That is what the third one says. Subgingival treatment of perimucositis and or periimplantitis surrounding 3 or more implant bodies.
So the first one can't be 1, 2, 3 because people are going to include 3 or less. Does anyone else read it? Sound it like that? Hear it like that?
So
yeah, I agree with you, Connie.
So Connie, this is Siobhan. So we kind of use the traditional scaling and root planing codes for natural teeth. And we tried to describe the same scenario technically, because remember, we're talking about a lot of our planning and ideas and needs are in support of the patients who have full mouth implant dentistry. So for example, I have a case coming up where the patient has 16 implants, 8 in the maxilla, 8 in the mandible. And he has a full arch cemented bridge, which is not going to come off. He also has residual cement in many areas. So I have to go subgingival, and he needs to be anesthetized with local anesthesia. So, you know, just like the patient who has natural teeth, technically we wouldn't anesthetize the whole mouth. So I'm having him come back so I can do, you know, one half of the mouth, the other half of the mouth. So one of the differences is that I'm not scaling I won't be scaling his implant bodies. Well, obviously the ones that have cement will have to be scaled off, but there are others that don't have cement and it's just an overload of biofilm. But anyways, so that's where that comes from, because the scaling and root planing colds for natural teeth are 1 to 3 teeth, or, you know, the 4-3-4-1 and the 4-3-4-2. So it's you know, we can definitely go into more depth and be more scientific about it, but I'm assuming that the people who are, you know, on the board for these codes, you know, their minds aren't there yet, which is why the codes that we do have right now for patients with implants are more for those patients with, you know, one single implant in their mouth. So like I said, we need something to support the more advanced cases. So technically for some of the patients that I'm treating, I don't have any codes to describe what they're doing. And I know that in the new CDT book, there's a code for unspecified implant procedures that you'll have to use a narrative. So going forward, that's what I'm going to attempt to submit. Does that help?
Siobhan, yeah, no, I think you just, thank you for that explanation. It was amazing, and you guys did an amazing job, and I think mimicking the current wording with perio scaling, I think that's genius. That will make it simple. What I was saying, to be more simple, when Jill read it, it was 1 to 3, and then the second one was 3 or more. It can't be both ways. It's either 1 to 3 and then more than 3.
Well,
you understand what
the
I'm saying?
scaling and this is Kathy. The scaling and root planing is 1 to 3, and then the other one's 4 or more.
Right. And
So if you could,
that's
yeah,
what Connie's trying to say. Yeah.
That's what I was trying to say.
Okay, I see that.
Okay.
Yeah. Yeah.
Thanks.
It was just
Yeah,
in
I see
wording
that.
that.
Thank you.
Okay.
Right.
Okay. All right. Good job, group.
Okay.
Wow. Thank you. I'll be anxious to see all that in writing at the next meeting. Have a, you know, the actual descriptors in front of me. That'll be great. Okay. Moving on to, anybody have any other questions for the implant group? Okay. Moving on to Jeanette. Is Jeanette here?
Yes, Jeanette is here. Can you all hear me?
Adjunctive General Services.
Okay, I have an amazing group of women to work with, and they are so creative. I love that because sometimes I'm not. So with the adjunctive group, we were like, okay, what do we do? Which ones do we pick? So someone came up with the idea of going on Facebook and asking the hygienists on the different Facebook pages that what codes would they like to see or would be available to them. And we had, I don't see where, do you have the paper that I sent to the Patties?
I was not given that when I put this together, so I'm sorry I did not have that.
So there were several different topics brought up by the people on Facebook, and we picked 2 and kind of ran with that. You know, opioid dependency is obviously very much in the forefront right now, so we thought maybe an opioid dependent counseling code where we could start talking to our patients about it. And then we also thought maybe a post-therapeutic treatment code would be nice. And this is, you know, a lot of times we'll bring our patients back, you know, anywhere from 4 weeks to 12 weeks out from periodontal therapy, and there's no code for that, and we are not allowed any reimbursement for that. So we thought if we came up with something that we could code out and possibly get reimbursed for it, that would be better for our patients and also easier for us to use. So with that post-therapeutic treatment, we narrowed it down to we would do the periodontal assessment, the full mouth probe, any additional scaling if we needed to, polishing at that point, because I can't remember if it was Teresa or Jamie that brought up the point, our patients really want to be polished. And many of us choose not to do that at the periodontal therapy appointments. And you could do that at this post-therapeutic treatment appointment. And then you could also provide adjunctive services. And we've thought, that could be an umbrella. We wouldn't list all of these, but these are what we were considering the adjunctive services at this appointment. If you want to use the antimicrobial agents or the perioscope, or for me, a laser. But obviously I would never say laser because they all don't want to hear that. So those are the two options that we thought we would float by y'all.
Mm-hmm. I like that opioid dependency myself. Anybody else have any comments? No. Well, then I would say,
well, sorry, this is Connie. This is Connie. Go ahead, Tammy, since you're on there in your phone, on your car phone. Go ahead.
I'm sorry, this is Alicia. So what I was thinking is, there's codes for those things, and I, as a hygienist, I understand the 4 to 6 week thing, but it's all about reimbursement for the patient. But there are codes, the 0180, you redo a perio chart at that time. There's a code for subgingival irrigation. So I feel like, there's codes for those things, and of course we want people to get reimbursed. So, just bringing up a new code where there's kind of already those out there isn't going to make these political people want to reimburse it. And, that's just my opinion.
Yeah, usually the D0171 reevaluation postoperative office visit was what we would be leaning toward for this post-therapeutic treatment code.
But see, we wanted it more than just an assessment. We wanted actual treatment to go on.
Okay.
That's where we were hoping we could slip something in.
Okay.
So that treatment, you have the local, you have the 4341. If you need to scale 1 more 2. So if there's something that there's not a code for in treatment, which the only one I heard mentioned was laser, then it is kind of irrelevant. There are codes for treatment.
Yeah. I hear what you're saying, Jeanette. I mean, I would love to, we could float it and see, if making it that the descriptor is specific enough to show that it's all encompassing, and that it would be if the research could back up doing A, B, C, and D at an office visit. So it'd be all the same. The research would back that up and point out it could be cumbersome to break it apart, as Alicia said, with all these different codes. We'd have just one super code, if you will. So I think it'll depend on how it's presented and what rationale and what research you have to back up that particular treatment. So I would, go ahead and keep moving on that, but really tighten it up to what you expect to be done during that specific treatment. Okay, that makes sense?
Okay.
Okay. The thing that's on the slide that's on the screen belongs under your group, and it was something that we talked about a couple times ago, and it's kind of an editorial thing, but it would come out of your group, and we can certainly help you fill out the code change forms. That we wanted to take the word bleaching out of all these and put whitening, so that, because we don't know if what is bleach being used or another product. I mean, there's all sorts of whitening products out there. So we can work with you at filling out those code change. That.
Thank you.
You're welcome. Okay, we've got about 5 minutes, so let's kind of move forward here, because where do we go from here? A lot of different ways. If you go down to the next slide, for those in the preventive and in the implant, need to start filling out the paperwork. And if for the codes that they've already talked about, the other groups, if you're going to be, this is the actual form. It's in the Dropbox under tonight's meeting. It's a 3-page form. I will get the actual instructions, but I've filled out a number of these, so I will certainly be the resource person for anyone submitting codes. But we need to start filling out this CTT code action requests. And the biggest key is the rationale. And on the next page, it isn't in the slide, but the next page actually has steps on all the information that you need to be submitting. So as Patty had mentioned in the very beginning, being part of this group is also an educational process. So not only 1 or 2 people are filling out these request forms, that everyone gets to have that opportunity. So let's go to the next page, because we've got a countdown to the CMC meeting, and here's it is. Our next meeting is Sunday, September 16th. I would expect each group develop, review any suggested code submissions that you might have, and begin to complete those code change action request forms. The next meeting is Sunday, October 21st, where we need to finalize them and review the actual change forms, because on November 1st, those puppies have to head out to ADA headquarters. So time is of the essence right now. The biggest thing I've found in doing this over the years is getting the research, getting everybody's input, letting everybody have a hand in doing the research and the writing and the discussions. So this is our timeline for these code changes. It looks like we'll be doing 4 from preventive, although we're looking at a couple others, and 4 from implants. If adjunctive has their 2, there's 10 codes. So it's a lot of work. But, you know, I think this is honing in. Instead of having 6 all over the place, we've got it really narrowed down to what we can do. So if any of you out there who aren't already assigned to a work group, if you have one, you say, hey, I'd like to help with that, please let Patty know so she can give you the information and hook you up. Again, this next DCC meeting is Sunday the 16th at 7 Central. Patty wanted me to remind everybody the next mastermind group, next slide, is on the 5th at 8 p.m. And Patty B, I don't know who's speaking. Do you know?
Sorry, every time I unmute myself, this is what happens. No, I'm not. I don't remember who's speaking.
But they've all been good, so everybody needs to be able to
pull
do
it
that.
up. I have to look at my phone.
That's okay. That's okay. But anyway, I've got 1 minute to go. So the next slide is just, again, thank you so much for your input. Howard and I in the preventive group will get our heads together on see what kind of language we can, that'll be helpful to everybody. And implant people, same thing. Reach out to any of your advisors if you need any additional information. But we thank you so much. And if anybody has anything else.
Kathy?
Yes, Tammy.
Okay, Kathy, I was able to connect with President Brereman.
Yep.
So I am going to inform you all that today the Executive Committee of ADHA did approve for a task force to be developed on a definition for oral prophylaxis. So that has to go before go to our board yet. But I was informed by Michelle that I could let this group know that today the Executive Committee did approve the development of that.
Okay. Good.
Tammy, what's the timing on that with this timeline that Kathy just mentioned to us as far as the timeline, you know, the deadlines for ADA submission? How likely is it that the task force will have a working definition that we could perhaps work in tandem
Yeah, I think that was Noel, and
Yes, it was. Yeah, sorry about that. Yes, it was.
Yep, the timing for the group to report back will be for our winter board meeting in 2019. So 2019. So as you can imagine, they'll be doing a significant amount of work, reviewing the research and doing all of that. So it will not align with what you all are talking about, but it does put you in a position to be aware of the process, and of course ADHA's ability to support something that is proposed would be dependent on having policies. So
right, got it. Okay, great, thank you.
Okay,
and
so Tammy, I have a question. This is Jill. So that definition won't go. That'll go before the House of Delegates. You're saying to be submitted. Oh, that would be my understanding.
Yes, if a definition is the outcome of that, and the intention is to have it in the ADHA policy manual, that would be correct.
Right. So that will be in June of 2019.
Yep,
yes, I think that's correct.
Tammy, I might say, just for your information, Howard and Alicia Lopoli are doing all the research on the Profi stuff. So you guys don't have to recreate the wheel. I'd strongly suggest you reach out to them for their input on the research that they're finding.
Yep, I'll let Michelle know that. That's why I reached out in the interim here, because I wanted to make knew that. I mean, we just did that today. I'm on the road back from the meeting, so I will certainly let her know that, Kathy. Thanks.
Okay, all righty.
Kathy.
Cool. Yes.
Kathy, this is Patty.
Yes.
The guest for the mastermind session is Jan Palmer, and she is the author of the book Oral Health and the Oral Physician: The Secrets of Medicare and Dentistry, and she is going to be talking about Medicare.
Oh, cool.
So that's who it's going to be. So it's Jan Palmer.
Awesome. Thank you so much.
And you'll be getting the newsletter soon.
Okay. Perfect. Well, thank you all. There's still 25 of you left. Again, thanks so much for hanging in there. And any questions, you can reach out to any of us. Any comments, if you wake up in the middle of the night and go, oh, I thought of the language, then let us know. Okay. We will put it to good use. Yeah, never do that. We're stronger together. So thank you for all, and good night.
Night.
Good night. This should be in the Dropbox soon. Thanks.
Okay. Thanks. Bye-bye. Thanks, Patty.
Yeah. You're welcome. Bye, Kat.
Bye.
Hello?